Good morning. Good morning. Today is, hey everybody, we're going to get started. Oh, afternoon, sorry. You're right, it is afternoon. No, actually it says good evening on my script. It's afternoon. Good afternoon. Today is December 11th, 2024, and the time is 4:01. As a quorum of the board is in attendance, I'd like to call to order the meeting of the Central Health Board of Managers. So, managers, I'm going to tell you the order we're taking things up today. We're convening our Board of Managers meeting first because we're going to cover item number 1 on the regular agenda. We need to do that first due to the limited availability of the presenters on that item. We will then have a closed session to discuss items from the Board of Managers and also the Budget and Finance Committee. So we'll go into closed session and cover both of those things in closed session. Once we reconvene from the closed session, we'll recess the board and proceed with Budget and Finance. So that will keep us from having to go in and out of executive session. Also, we have taken a few things off the agenda today just for the sake of time. We will not be having the executive committee meeting. There's no need to have that today. And we will not be considering items 3, 8, and 10 on our Board of Managers agenda. And again, that's to keep us from being here till 10 o'clock tonight. So finally, I would like to announce that in order to make it more accessible to community members, we will hold public communication for the Budget and Finance Committee and the Board of Managers meeting at a time certain of 5:30. So with that, managers, we're going to go to item number 1 on our regular agenda. We're going to receive a briefing on Austin Community College and Central Health Partnership opportunities. Dr. Lee and Dr. Shalsa will be presenting with Dr. Russell Lowry Hart from Austin Community College Chancellor and Dr. Nina Almasi, Austin Community College Associate Chancellor. Would you like to say anything, Dr. Lee, before we get started?
Sure. Thank you, Chair Kitchen. I just want to provide the warmest of welcomes and a shout out of love and appreciation to Russell and Nina and their whole teams, as well as to Dr. Alan Shalsha. What we're about to hear begin with some generative conversations and between Nina and Alan, and really evolved through a series of meetings to bring us to a place where I hope that what we have the opportunity to share with all of our Board of Managers today will feel like an exciting opportunity to recognize the many shared values that we have, the shared people that we serve, and the shared work that we can do when we allow ourselves to think differently and take part of the wall down between health and education. And so I'm just so honored that Russell and Nina willing to take the time to do this tonight. And I can't wait to give everyone a preview of what we're thinking and get your thoughts. So with that, Russell, may I hand over to you for any framing remarks you'd like to make, and thank you for being here, my friend.
Well, Pat, you know I can't not have remarks. So when I met Pat, I was moved by the vision that you all are creating as an organization. I was challenged by the vision to create systems that love people to health, and was struck by the vision that you all are creating because it aligns so much with the vision that we're creating at Austin Community College. Our vision, adopted by our trustees, is loving our students to success. So honestly, I thought I was the only leader in the country talking about love so intentionally until I met Pat, who does it more intentionally and more effectively than I do. So I've learned a lot from him. But at Austin Community College, our commitment to loving our students to success starts with really knowing who she is. And so I want to introduce our typical student and why I think her future is so intertwined in our ability to figure out opportunities to serve her together. Our typical student is named Ashley. She's a 26-year-old woman of color. She's a first-generation college student. She's raising 1.2 kids while working 2 part-time jobs. And she's smart, and she's ambitious, and she's the future of our community. But she needs us differently than she has needed our community's networks and our educational supports. She is our typical average student for Austin Community College. Of the 80,000 students that we serve annually, she's the typical student, and most of the time we think of the 18-year-old that just graduated high school. And that student is an important constituent, but our typical student is your typical patient. And when I started at ACC and wanted to know what was happening to her, and I hired a lot of students as secret shoppers to help me know how she was experiencing the college. And the things that I learned from her and about her are instructive to the opportunities that we need to parse out with each other. That the biggest barriers to her success in the classroom have nothing to do with the classroom. Childcare, healthcare, transportation, housing, food, legal services, social supports. These are the biggest challenges that my students bring with them, and their solutions can't just be something that we do in isolation from the community, but have to be something that we build in partnership with the community. And that's why I think we're here, is to talk about what those opportunities might look like, and both in terms of educationally and ways that we can support our community, but in terms of programming and how an alignment and integration might not just love Ashley to success, but to love her and her family and our community to health.
Thank you so much. Good afternoon, Chair Kitchen and managers. I wanted to start also by thanking Garrett Groves, Vice Chancellor of Strategic Initiatives, who's really been critical in looking at opportunities and exploring what the future may be as we consider these opportunities together. Then my partner in crime, Nina, wanted to touch on a program that jointly with ACC we've engaged in, and we are now in our 4th cohort of jointly training medical assistants. So this initiative started about a year ago, would not have come to fruition if it wasn't for Nina and her leadership, and basically bridging kind of all these opportunities that we had as we built this program. That program we initiated because we looked to the future, and as we build the healthcare infrastructure that our patients deserve, we knew there were workforce challenges. And so we wanted to start a medical assistant program right as we started the build of our healthcare infrastructure. Part of the goal was to provide the resources for those medical assistants to have funding to attain their education. And part of the goal was to recruit those medical assistants from communities that we serve. After this 4th cohort graduates, so they are now recruited, they will start in January. Once they graduate, we would have recruited close to 40 individuals from communities that we serve, paid for their didactic education, which our partners provided, right? So an unbelievably excellent education. And then we funded their internship within our environment. We then hired them. They were hired by Community Care. They were hired by Peoples and by Lone Star. And so these are folks from our community now serving the communities that they came from. And that would not have been possible without our partners that sit at the table with us today. And I think That speaks to what may be possible. 15% of ACC's student body are housing insecure. 45% of Austin Community College's student body are food insecure. There is so much overlap between the students that they teach and the folks that we provide healthcare to. They improve equity through education. We improve equity through healthcare. The two together, I mean, what is possible? What could be possible as we partner with them? When we look at the infrastructure and the needs within the healthcare space, the techs, whether it's diagnostic techs, whether it's MAs, whether it's pharmacy techs, we recently met with some of our hospital partners and asked them what their stresses were. And they spoke to the fact that some of these diagnostic and pharmaceutical techs are some of the sought out unicorns that are so hard to find in today's environment. What if we actually recruit them from the environments, the communities that we jointly serve, and we train them together, right? And this is what, as Nina and I started to talk, we thought, I mean, we talked about one program and then another program, and then we also focused on healthcare. And we looked at, sorry, could we please go to the next slide? Got so caught up in the excitement of what we may do together. You know, if we also look at healthcare environments, we could potentially build these environments to provide opportunities for the training, fund the training, and provide access to care for the students and for our communities. Next slide, please. What Nina and our goal is today is really to talk about some of these earn and learn models, right? And Nina has the expertise. She's actually going to speak very specifically about some of these avenues for learning and career pathways as well, so that it's not just a one and done, so that once we onboard somebody, they can progress within our institutions. We're going to talk about and explore a theoretical clinic build, which, you know, for those who have visited our airport administrative location, the Highland Mall for Austin Community College is right across the street, right? It takes about a minute to walk from our environment to their environment. And many of you may remember the old Macy's that sits there, that used to sit there. What if ACC would consider us jointly building out that space, whether it's 100,000 or 200,000 square foot, you know, of clinical and social determinant of health possibilities? And we're going to talk a little bit about, you know, what that may look like. And then ACC has shared with us that, you know, if we start with an N of 1 and we take a go at this, they're open to looking at their other facilities within the county that potentially could serve in partnership with us for a bunch of different uses, including potentially housing for some of our under-resourced communities. And with that, next slide, please. And with that, I'm going to turn it over to my partner in crime.
Thank you so much, Dr. Shalsha, and good afternoon, esteemed Chair and managers of the board. My name is Nina Almasi. I serve as the Associate Vice Chancellor for ACC, and I too want to express my excitement and gratitude for joining you today to talk a little bit about not only what we currently offer at ACC in our health science, but also kind of touching on the potential of this partnership. So at Austin Community College, first of all, I want to express my gratitude for the great work that Central Health does in advancing the whole person care in our community. from our perspective, we are deeply committed to preparing and nurturing truly the next generation of healthcare workforce. And we recognize that we cannot do that without having strong partnerships in the community with healthcare and community organizations. And ACC has a proven track record. I don't want to say health sciences, but truly the college has a proven track record of establishing meaningful and impactful partnerships in the community to not only prepare our students to succeed, but also serve the community. And health sciences is no different. For those of you who may not be familiar with ACC Health Sciences, we have 14 nationally accredited programs. Each of these programs may include level 1 certifications or even institutional certificates, associate degrees, and our nursing program, which is a bachelor's degree. We have nursing is the big one, surg tech, sonography, rad tech, pharm tech, HIT, health information technology, vet tech. The list goes on. I always say we can almost staff a hospital except the physicians, anesthesiologists. I mean, between all the programs that we offer, right? I think so. We are just so grateful that the community has entrusted ACC with the healthcare workforce development. As Dr. Shalsha mentioned, some of these are currently we are in critical shortage, including nursing, of course, rad tech, surg tech in our region, pharm tech, and followed by sonography, other areas, dental hygiene, but these are the big ones. So one thing that we as a college are really committed to is, as our chancellor mentioned, is providing opportunities to students to meet those basic needs and challenges so they can focus on studying. And one of those is working, right? The majority of our health science students work, and they work in healthcare. So we are so grateful that through some of the partnerships that we have had, we were able to develop robust earn and learn opportunities, including internships and apprenticeships for our students. We have not scaled those yet because they are very new, and we are looking at the data, and the data is very promising. For example, a nursing internship with a great healthcare partner we have, those outcomes are very promising. So now we know it works. Our students appreciate the opportunity to learn while they are getting credit for those clinical learning, literally hours. They're getting paid for them. So this is a reason why I personally am so thrilled, not only because of the mission alignment, but what this potentially can do for our community and even potentially serve as a national model. I would think if we, as we explore this for a true education, healthcare and community partnership in the hopes to loving our community to health and success. And we have a few examples here, and these are the programs that we currently have. We have stackable pathways in our health science programs. Some of those include pharmacy technician, the paramedic program. We have an EMT to advanced EMT to paramedic, stackable. These are truly stackable credentials. We have I mentioned the pharm tech. Our rad tech, we have an LMRT that we newly developed, limited medical radiography technologist that is literally the first year of our associate degree in radiology technology. And the MA to LMRT, we have not developed that yet, but we're working on it. So as Dr. Shalsha mentioned, this partnership potentially could incorporate some of these pathways that we currently have. For example, in our nursing, we have the CNA program, we have the LVN. And by the way, if I may, thank you for that very kind credit, but I have to give credit to the team of the Continuing Education Department at ACC. They did incredible work in making that happen. I was just a connector, but I appreciate your kind words. We have an LVN program. We have a mobility track, and that is for our LVNs, paramedics, RAD technicians who want to become registered nurses. And we have an RN to BSN program. So these stackable pathways have been established. So it would be a great opportunity through this partnership, perhaps be able to scale some of these pathways that we have already developed and hope to serve more students through. And then we have listed other opportunities that is definitely worth exploring. And again, thank you so much, and I'm here to have questions answered, if you'd like.
All right, thank you. Next slide, please. Post-COVID, Austin Community College conducted a survey with their students, and through that survey, they showed that students have critical need in specific clinical areas. That coupled with potential program development and need within the clinical space, and then looking at clinical build-out needs for our patients, bringing all of that together, we have the start of potentially a clinical program that will serve our patients, serve as a training site for some of the programs, if not all of the programs that Nina mentioned before, and generate kind of a workforce for our future build as we continue together to build that workforce infrastructure. I'm not going to go through all of these in details, but I do want to touch on a couple of them. Dental services, there's critical need for adult dental, dental assistants and hygienists to create an opportunity for them to train in a real clinical environment requires significant build out, as well as coupling with the critical need that we have, significant opportunity. Looking at that Macy's campus and really exploring what may be possible. Is it a convenient care? Is it an urgent care? How do we do wellness visits? How do we provide immunizations? How do we provide acute care for individuals who maybe, are responsible for a child undergoing education but not feeling well? They don't have the opportunity to go to a provider in any other fashion. If we can offer a one-stop shop while providing a training opportunity, what an amazing opportunity overall that would be. Diagnostics, I think Nina really explained kind of the critical need. And I pointed to the fact that there are those, it's like finding a unicorn. If you find, some of these really trained diagnostic techs that are out there, I think everybody's arm wrestling for them. We really need to develop a workforce in that environment, as well as to provide access for our patients, CT, MRI, FibroScan, ultrasound, X-ray, that is independent of our patients having to go into the hospital to have those diagnostics. Lab services, lab tech, we can build out that environment and also, do draws and conduct some of those diagnostics on site. Pharmacy is a 340B, is a whole retail pharmacy. I think we still have to explore what that looks like, but again, generating that workforce, providing resources to our patients, and access to healthcare, behavioral health, mental health and counseling, critical needs for our patients in general and for the ACC student population, for women's health, sexual and reproductive health. One of the opportunities, and the chancellor has been, really clear when we sit and talk about the opportunity for that Macy's, the Macy's environment, if that could potentially serve as a drawing point for the community, as an environment where the community can gather. Is there an opportunity to build a full-scale gym, right? If it's a basketball court, if it's an actual gymnasium where students can come on site, have some opportunity for recreation. They could have outdoor sporting opportunities. We could couple that with PT, OT, and some of the other resources, again, for training, and where our patients, have the opportunity to access care. Really unique opportunities there. Teaching Kitchen. As we start caring for our community, members jointly, for individuals that have cardiovascular disease or diabetes, can we actually teach them how to create some of these recipes that, let's say, for cardiovascular patients are heart healthy? Can we serve that? Is there a restaurant that's coupled with that? ACC has a culinary program. So if we touch on the dietary aspects, the culinary aspects, and set people up for success, as they progress down there, with their disease progression in these various care continuum environments, significant opportunity there. And then we'll touch on the social determinants of health in a second. Next slide, please. And this is really the opportunity for a one-stop shop. So if there is a guardian or a parent that is undergoing education, if there's an opportunity for an on-site daycare, what a great resource that serves, for that individual to receive their education. They can receive their education, receive their immunization, and go to class. Having resources for women, infants, and children, so WIC resources, legal assistant eligibility, food pharmacy. This is just, again, touching on the exploration of what may be possible as we jointly consider a build-out of that Macy's space. Next slide, please. We've talked about respite quite a bit, right? I think if we look at 23-24, FY 23-24, I think we had about 145 patients that entered our respite environment. There is a subset of those individuals who, if they actually had an opportunity for an education, could change their life circumstance, right? So what if jointly with our Austin Community Care partners, right, they provided the didactic education, we provided the internship opportunity jointly, we funded that opportunity, we also considered housing, if there's a possibility for that, and then we hired them and reinvested that knowledge base and those skill sets in the communities, right, that these individuals came from. Now we're talking equity, whether it's education, whether it's health, whether it's life, right? This is changing lives. And this is the opportunity, I think, that we truly have if we do this together, right? So this is conversation really number one, and really just starting the exploration of what may be. And I'm going to hand it off to you, and thank you for listening.
I think there is a lot of opportunity for integration and alignment in a lot of different areas. And it's exciting to dream about those. Every one of those opportunities creates a long list of questions, and we need to go explore the answers to those questions. So I just appreciate the opportunity to introduce the conversation and deepen our already existing partnership and explore new opportunities to build together. And we're serving the same community that has the same need. And I think the opportunity we have is to align those services in a way that move people into health and changing generations in the process. I'd love to continue this conversation, and if there are any questions, we may not have answers yet, but would love to engage them if you have them.
Well, thank you all very much. This is very exciting. I appreciate the vision. There's a lot of potential here. So I am going to note that we have 5 minutes left for this item. Because it's so important, I'm going to go around the room and and have folks ask one question. Let's keep it tight, otherwise we are going to be here till 10 o'clock tonight. But I also want to note that this is, like you said, this is our first conversation. So we will need to, there's a lot of work to be done, obviously, that you all are, I assume that you are embarking on or about to embark on. And I would invite some presentations where we can spend more time with a couple of our committees, our infrastructure committee with regard to the space. So if that's acceptable to the chair, that might be a good place to really dig into some details there. And then of course there's programming that perhaps our SPC committee could dig into. And then of course there's the dollars that all this is going to cost. So the Budget and Finance Committee would want to hear some more about that. But I'm excited that y'all are bringing this idea to us at this stage, that we can hear about it and start to think about it. So I'm going to ask folks to keep it really tight. And I'll start on this side of the room and we'll just go around once, understanding that we'll get to talk about this again. And I hope you'll engage us. I think it'll be important to engage us, multiple times as you go down this road. Because it's very exciting and there's lots to talk about. So would you like to start, Manager May?
Just briefly, thank you for being here. But more importantly, I'm excited, like you guys are, about the vision that you have with respect to this program. I would be most interested in learning as this progresses and as you continue to explore this whole residential continuum concept that you have, where you include your respite, you do the training, you include the respite, then of course you'll do potentially the internships, and then of course, hopefully into the workforce. I'm excited to hear more about that.
Okay. Manager Jones?
I'm sorry, I just got here, so I can't really speak.
Oh, okay. Manager Matwani?
Thank you, Chair. Echo the positive vibes about having y'all here. This is uniquely close to me, both through my lived personal experience and engagement with post-secondary education, and how stigmatizing and dehumanizing it can be, frankly, when barriers like social determinants, or as I guess we're wont to say nowadays, non-medical determinants, may prevent us from being able to smoothly attain a post-secondary education that I believe we all have the right to. And it's also close to me just because of work that I've done, and Garrett can tell you that years ago, that in some discussions we had around economic mobility, that particularly this element of pathways with stackable credentials is something that's uniquely important. And and I certainly applaud the Infrastructure Academy that I know y'all are working on with City of Austin and Workforce as well. But to me, this is the real Infrastructure Academy. This is the real Infrastructure Academy that's investing in communities while literally working with the people from those communities, investing in those folks' education, such that not only will they bring, I think, the cultural competence that we're frankly starving for in many ways when we serve members of our community, but also enrich those individuals with opportunities to access wealth by means of stackable credentials. I'll throw in that, I'd love to see an even lower hanging fruit of community health worker, maybe somewhere in those credentials to find where those pathways may lead, and also perhaps possibly a focus on behavioral health. Thank you, Drs. Lowry, Hart, Almosi, and of course, Dr. Shalsha.
Thank you. Manager Brinson? Dr. Brinson?
Well, my only question is, could you tell us your top 5 funding providers at this time?
When you mean, what do you mean when you say funding providers?
Well, where do you get your money?
So, taxpayer funding and state funding, tuition funding, and then federal, local grants, and then philanthropy are our top 5 funding sources.
Dr. Martin?
Thank you for the presentation. A question, this is going to require a lot of faculty resources. Are those
resources available or visually, I mean, in the future for ACC?
If there are students, there will need to be faculty, and one creates the support for the other. So yes.
So there'd be, okay. The other thing, I just would like to really strongly voice my support for this program. I think this is phenomenal. I think the idea of the stackability is particularly relevant. As people find different barriers in life, they may say, that's enough, and I can get off, I have my education. So I just want to really commend you guys. I think it's just a wonderful, wonderful proposal. So thank you.
Thank you, Manager Valadez.
I want to thank you for about the 10th iteration of this concept being realized by y'all. This is something that was brought about in the 60s, in the 70s, in the 80s, in the 90s. It used to be the old grow your own concept when Crystal City was cut off in the educational field during the days of Raza Unida. The whole city created their own way of doing things and running the schools, teaching the kids, blah, 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 all these certifications, etc. So you had onslaughts of people from around the United States that circulated around this homegrown concept and taking people out. And in Isleta, the Grow Your Own Again. So they've been doing that and highly successful at it for decades now. People are just realizing that or not realizing that, and that's how they got all their all their regular students graduated from top colleges and universities throughout the United States through the Grow Your Own process. And one of the things that we have talked about in this community for at least 4 decades, trying to get the school districts to align with either community college or University of Texas into the various programs that are offered through them. So these are things, if you look back on newspaper articles and talk to some of the old educators, if they're still alive, the old planners, this is exactly what is needed to build a community and a workforce and take care of your own needs by growing your own. So I'm very, very supportive of you in doing this. Like I said, this, the forward-thinking visionaries of educators, the education community past, and the civil rights community past, when they knew that people of color were being excluded in many of the programs, they would grow their own, okay, through entities like Lincoln Juarez that was here in Austin and other areas. So I'm very glad that you're doing this, and anything we can do to support you, thank you.
All right, thank you all for being here. I would just ask to you don't need to answer it now, but let us know your timeline for bringing back details to our various committees. And I think that'll give us all an opportunity to dig into it in detail and ask the kind of questions that we have. So I'm going to move us on at this point. I want to say thank you all for coming. Appreciated hearing this. It's an exciting idea. Okay, managers, we are now going to open our Budget and Finance Committee meeting, and then we're going to transition to closed session. So, let's see. Good afternoon. Today is December 11th, and it is 4:39. As a quorum of the committee is in attendance, I'd like to call to order the meeting of the Central Health Budget and Finance Committee. So now, let's see. We're now going to proceed to the Budget and Finance Committee agenda. Oh, no, that's not right. Okay. So I'm going to move us into executive session. So, and again, as I mentioned earlier, we're going to take items for executive session, both from Budget and Finance Committee and from the Board of Managers meeting. So, I announced that well, first I'll read item number 2 from Budget and Finance, which is discuss and take appropriate action on the calendar year 2025 budget for Sendero Health Plans. I announced that the committee is convening in closed session to discuss agenda item number 2, under Texas Government Code, Section 551.085, Governing Board of Certain Providers of Healthcare Services, and Texas Government Code, Section 551.071, consultation with attorney. I'm also going to announce the two items from the Board of Managers meeting that we are taking in closed session. It's item number 7, which is discuss Central Health owned or occupied real property and potential property for acquisition, lease, or development in Travis County, including next steps in the redevelopment of the Central Health downtown campus, administrative offices of Central Health Enterprise Partners, and new developments in eastern Travis County. And then item number 9, which is receive and discuss a briefing regarding Travis County Healthcare District DBA Central Health versus Ascension Health. So I announced that the board is convening in closed session to discuss agenda item 7 under Texas Government Code Section 551.071, consultation with attorney, and under Texas Government Code Section 551.072, deliberation regarding real property. And then agenda item number 9, is under Texas Government Code Section 551.071, consultation with attorney. So managers, we're going to move now into closed session at 4:41. Okay, managers, we're going to hold public communication, and we're going to do it as part of the. Oh, sorry. Sorry, that's right. Okay, we are coming out of closed session. The time is. I think I have to do the beginning of open session. I already did. Okay. It's the 11th, and it is 5:45, and we are coming out of closed session for both Budget and Finance and the Board of Managers. And we're now going to go into open session with our Budget and Finance Committee to hear our public, pardon? And recess our Board of Management. Okay. All right, so we will now receive public communication as part of the Budget and Finance Committee. Do we have any public comments?
Yes, Chair Kitchen. We have 3 signed up to speak tonight.
Okay. If you want to proceed?
Yes, I will now read off this night's public communication. I'm gonna say it in English and Spanish since we do have a couple public comments in Spanish tonight. So when called upon to speak, please introduce yourself by name before beginning your comments. Also, if your comments will focus on a specific item or issue on the agenda, please indicate the full item number after your introduction. Each speaker will be limited to 3 minutes. Staff will be timing each speaker and will announce when a speaker has reached their time limit. To ensure the efficiency of the meeting, once we have let speakers know they've reached their limit, we will allow 30 more seconds to wrap up their comments before they are muted. Due to the restrictions of the Open Meetings Act, the board may be restricted in discussing any items that are not listed on the agenda for this meeting. The board may choose to set aside any new issues for discussion at a future meeting. Al ser llamado para hablar, por favor, preséntese con su nombre antes de comenzar sus comentarios. Además, si sus comentarios se centrarán en un tema o asunto específico del orden del día, indique el número completo del tema después de su presentación. Cada orador tendrá un límite de 3 minutos. El personal estará cronometrando a cada orador y anunciará cuando un orador haya alcanzado el límite de tiempo. Para garantizar la eficiencia de la reunión, cada vez que se informe a los oradores que han alcanzado su límite, les permitirá 30 segundos adicionales para concluir sus comentarios antes de ser silenciados. Debido a las restricciones de la Ley de Reuniones Abiertas, la Junta podría estar limitada para discutir cualquier tema que no esté listada en el orden del día de esta reunión. La Junta puede optar por reservar cualquier nuevo asunto para discusión en una reunión futura. Hoy recibimos 3 presentaciones para comentarios públicos. This evening we have 3 submissions for public comments. I'm going to call them up at the same time. They have a presentation to show. They are with the group MISMA. Hoy tenemos a 3 oradoras que gustarían hablar y las voy a presentar juntas porque tienen una presentación y son con el grupo MISMA. So without further ado, I would like to call up Magdalena Alvarez, Alma Ruiz, and Rosario Nava. Y Magdalena Álvarez, Alma Ruiz y Rosario Nava, si gustarían subir ahí al... Sí, perfecto.
¿Te gustaría presentar, Rosario? No, si no se presenta.
Buenas tardes, mi nombre es Rosario Nava y soy cofundadora de MISMA, Mujeres Inspiradas en Sueños, Metas y Acciones, aquí en Austin, Texas.
So this is Rosario Nava. She's co-founder for the organization MISMA, which stands for Women Inspired in Goals, Dreams, and Action. My name is Alma Ruiz, and I am an organizer in MISMA, and I've been with MISMA since 2016. Si se quiere presentar.
Buenas tardes, soy María Magdalena Álvarez, soy cofundadora de MISMA,
También, como dice mi compañera, ¿verdad? Somos mujeres inspiradas en sueños, metas y acciones y más que todo para empoderar, para educar a todas mujeres trabajadoras del hogar aquí en Austin, Texas.
So Magdalena is co-founder of MISMA as well, and I'm gonna talk to y'all a little bit about what we do, and we have a presentation.
Okay.
So this is Rosario. She's from Mexico, and she's a domestic worker, and she's an organizer here in the organization. So this is our team. We don't have a staff, but we help organizing the organization. So everything started in 2013 in Casa Marianela. That's where we started. We're gonna try to go as fast as we can because we have a lot of slides. And we got our name officially in 2014, which stands for Women Inspiring Dreams, Goals, and Action. In 2017, finally, we registered the organization as 501c3.
Yes.
And we had a lot of challenges, but thanks to all the hard work Rosario did, we were able to do this. Our mission is to educate and empower the immigrants movement here in Austin, especially the domestic workers. So we have built a movement of brave women to organize the future, and so they can have, sorry, I'm a little bit nervous, respect and dignity in their place of work. So we define domestic workers as the people that take care of our kids, clean, do housekeeping, and take care of our elder. So in MISMA, we want to make sure that these domestic workers have our value in the place of work. We have heard a lot of stories where their work is not being valued. So we want to make sure that they know they have rights and their work is very valuable for our society. So this is the structure. We have a board, the organizers, we have committees, and our members. So as you can see, we are the organizers, and we are passionate about what we're doing in the organization. And we just want to show you some pictures of our committees. All of them are members of our organizations, and they are very passionate about what we are doing. So this is part of our members. What we do, we have an annual workshop where we teach them about what the domestic work is and what their rights are. We also do workshops through the year. And sorry, I'm very nervous. This is my first time doing this
You're
in front
doing
of a lot of people. But yes, every year we do workshops, and we are doing meetings every month, so we can bring all the research we find in the community to our active members. And this is our social media. We are also part of the National Domestic Workers, and we do monthly meetings where more than 500 members are connected. And we do participate in a lot of events with the National Domestic Workers. We go to the, well, we have a Congress every 2 years where we participate. And every month we attend their meetings. So another of our goals is to certificate, well, not certificate, but certified, yes, certified our members to become speakers, like to do our workshops. We give them a space where they can develop that skill. So we do this every year, and we want them to be part of our organization and giving them that space where they can become leaders. One of our event that we do every month is we call it social meeting. We do a meeting every month where we gather and we give them a space to talk. We have we've hold on, let me get my words together. We've noticed that the domestic workers are isolated sometimes, so we've been trying to figure out how to help them to make community. 70 or more % of the domestic workers are immigrants, so some of them don't have nobody here in the city. So mostly they're lonely and they don't have nobody to talk. So we try to make this event for them so they can socialize and make community with other domestic workers. This year we also brought a workshop to educate them about the history of the domestic workers, because the domestic workers have gone through a lot to fight for the rights that we have now. Mm-hmm. So we had these workshops that were provided by the National Domestic Workers, and our members had the opportunity to participate. And these are pictures from our annual workshops that we have. We have 5 consecutive Saturdays, and it's for 5 hours. And we provide them with breakfast and lunch. And we have had a lot of success with it because every year more domestic workers or women in general are like they sign up, and every year we have more and more. Our goal every year is to have at least 50. But every year, a lot of these women sign up for the workshops. So this is our team. All of them are members and volunteers, and they help us prepare the workshops for all these women. We started with the workshops back in 2018 in Casa Marianela, and from there we've grown a lot, as you can see in the pictures. We started with 12, and last year we had 60. Well, not last year. This year we had 60 signed up. About 80% of the women that signed up stayed as members of the organization. Well, during in 2020 we had a big challenge because we had to get all these women to be able to participate since it was virtual and they didn't had a lot of experience with the technology. We had a big challenge, but we were able to get the 50 women to sign up for the workshop. So this is the pictures from the last 2 years. We have grown a lot every year we get more and more women, and our goal is to be able to help more than 50 every year. So to be part of the organization, we just ask them to participate in the workshop and be active with us. So in MISMA, we learn, we educate, and we se me fue la palabra.
Train.
Yeah, we train and we have fun. So this is I don't have the words to say, but this is like did you know that some of the domestic workers are excluded from some of the rights in Texas and some of the protections and the minimum wage, yes. So this is some stories we have heard from our members that they have excessive work, long shifts, and I can't see. Oh, most of them don't have a signed contract. Mm-hmm. Well, these are the pros of being a domestic worker. We work independently. We can manage our schedules. We put the price for our work. We keep getting better with the experience. I can't see. Disponible de mejores tiempos. Okay. So what we provide our members. Okay, sí. Sí, por favor.
Some opportunities with MISMA is you can shape yourself professionally, you can improve workforce conditions, you can get involved in a community of people that work in housekeeping or in the house. You can also develop your public speaking and just language abilities. You can also develop yourself as a community leader, travel and get to know hundreds of workers all over the country and the National Alliance of Housekeeping Workers. Affiliated or they've been around since 2015. They've been contributing to the Trabajo Organizativo, nationwide initiative to organize workers with thousands of workers that work at homes all over the country. At MISMA, we have a committee that participates directly on tasks that are related to, que nos corresponden, I don't know.
Next.
Okay. Our commitment with this nationwide organization is as important as being a member of this organization as well. Next. 15 years of organizing work with this nationwide organization. All workers are essential, including workers that work at home and that are caretakers at home, and they deserve protections and they also deserve benefits.
Gracias. Thank you. Gracias, gracias.
Gracias.
Where, Misma? You have a question?
We'll just take one or two. We don't normally do that. I don't know if we can. We don't normally do that, but we're going to make an exception now. We're going to be very, very, very short. So, did you want to?
Yeah. Bueno, número uno, me gustaría decir que es súper importante que sea más fácil poder comunicar nosotros entre inglés y español. I want to say, first of all, I really wish it were a lot easier. I think in this day and age for us to be able to communicate back and forth in English and Spanish, and this friction, although it's a good movement, y esta fricción, aunque es bueno que estamos intentando, even though we're trying it, I think we could be better. Todavía podemos ser mejor en esto, y vamos a tratar, and I hope we'll try to do that. But secondly, I just know of Misma, I just want to say, because Rosario is like a hero. I'm really glad to meet all three of you. Qué gusto conocerlas todas las tres. And if maybe they might share about the connection to Central Health in particular, y si pueden compartir un poco acerca de la conexión con Central Health.
Claro. Este año nuestra capacitación fue con Central Health y lo que más nos gustó fue las facilidades que nos dieron. El trabajo que nosotros hacemos no es pesado porque es divertido, porque nos gusta ayudar a demás trabajadoras que necesitamos quien nos dé una esperanza. Y Misma es una señal de esperanza y somos una oportunidad. Por favor, Iván.
And so I just want to mention that she mentioned that the training that they talked about in the slides, the 5-week training actually happened at Central Health facilities. So I think that's really interesting and important for us to know.
Thank you. Thank you for.
Sí. Gracias. Gracias.
Thank you for being here.
Thank
we
you.
appreciate it.
And this concludes public communication for this evening.
Okay, we're now going to go back into closed session. So let's see. It is. Huh? What'd you say?
I believe that you were going to finish up budget and finance?
Well, no, we have budget and finance, and we have Sendero to go back into closed session for.
Right.
Okay. All right. So it is December 11th. It is 6:08, and we will be entering closed session. I read it once already. Do we have to? Okay. We're going back into closed session to take up item number 2 on the Budget and Finance Committee agenda. Okay, managers, we're coming out of closed session. It's December 11th, and the time is 6:32, and we're coming out of closed session. So we're going to go into open session. Again, it's December 11th, 6:32. And we're going back to our budget and finance agenda, and we're going to finish that agenda. So the first item on it is item number 2, which is the budget for Sendero Health Plans. I need a motion on that item, and I'll take a motion from Manager Valadez. Do you see it? The committee recommend, we're in the committee. You're looking at the right one?
I went to the wrong place. I move that the committee recommend that the board approve the calendar year 2025 budget for Sendero Health Plans.
Second?
Did you all hear me? Okay.
Okay. Second from Manager Brinson. All in favor? Aye. Motion passes. Okay, we're now going to go on to item number 4, which is, item number 3 we're not taking up. We don't need that one. Item number 4, receive the October 2024 financial statements for Central Health, including capital projects. Now, members, there's no presentation on this item, I don't believe. It's in the backup, and staff is available to answer any questions. So, do we have any questions at this point? It's just informational. Okay. We're moving on to item number 5, which is an update on Central Health Investments Policy and Strategy for fiscal year 2025. So this one is an action item, and if you all would like to proceed.
Hi, Nikki Riley, Deputy CFO. And
Debbie Laudermilk, Chief Investment Officer.
So they're 2 investment items that are related.
It's item 5 and 6, right?
Yes.
Okay.
We do this every year. In accordance with the Investment Act, we need to update our policy, adopt it each year. That's the first item, number 5. We don't do our own investing. We contract with Travis County and their investment office, and the CIO is Debbie. She does a fantastic job. We've been getting a lot more interest lately, and I'm sure it's all because of Debbie. But it does help us a lot. She's been working for Travis County for a very long time. I worked with her over there. She does an amazing job, her and Reagan. There are 0 changes to the policy for this year. So we just ask that you approve the Central Health fiscal year 2025 investment and collateral policy and procedures.
Okay. Do we have a motion on item number 5? Yeah, it's the committee. So let's Manager Motwani.
I move that the committee recommend that the board adopt the fiscal year 25 Central Health Investment Policy as recommended by Central Health staff and the Travis County Investment Management Department.
Second from Manager Valadez. All in favor?
Aye.
Aye. Okay. Item number 6. I need a motion on item number 6. Pardon?
You need to read item number 6.
Oh, okay. Item number 6 is receive, discuss, and approve the fiscal year 2025 broker-dealer applicants for conducting investment business. Do you have anything to say on that?
The only thing is there were no changes for this year as well.
Okay. All right. A motion on item number 6 from Manager Brinson.
I move that the committee recommend that the board approve the fiscal year 2025 investment broker-dealer applicants as recommended by Central Health staff and the Travis County Investment Management Department.
Second from Manager Motwani. All in favor?
Aye.
Okay. Thank you all very much.
Thank you.
Okay, we're now going to move on to item number 9, which is receive and discuss the quarterly operational report for community care. And this is a informational item with Joy Sloan and Dr. Nick Yagoda presenting.
I think we're gonna.
Did I get that right, or y'all going in a different order? Or?
We're gonna do first the operational report.
Okay.
And that'll be Tara Trower, our Chief Strategy Officer, and myself. Will be followed by Joy Sloan. Who
That's
will do
fine.
the financial report.
That is fine. So that's That's items number 9 and 10.
Great, terrific.
Okay, go right ahead.
Thank you, managers. It's good to see you all again. In light of, or in spite of what has been a challenging number of weeks or months for what is a complex relationship between community care and central health, I do want to sincerely and deeply thank you all for the extensive investment you have put into this health center program over the course of our entire existence. This program would not be nearly what it is were it not for the substantial support we've gotten for you all. And to be clear, we have not yet reached our potential. We stand at a very important opportunity, and this is the convergence of three key elements that make our collective futures very promising. The first element is that the health center movement has emerged as the most cost-effective avenue to equitable and high-quality health outcomes in the country. Far more effective than traditional structures that are usually hospital-centric, models which we have watched fail seemingly week after week this year under current financial pressures. Meanwhile, our health center program has proven itself effective and durable over and over again. The second element is that the local level of control afforded to hospital districts, allowing for a fully integrated system of care that responds to the immediate needs of the local communities, is a very unique opportunity. Not even in states with comprehensive healthcare coverage do you see the potential for the agility and tailored responsiveness that hospital districts offer. And then the third is that we are in the midst of a substantial transformation in U.S. healthcare incentives away from hospital-centric models towards ambulatory medical homes. You would be hard-pressed to find another health center program with the breadth of medical home services available for such a complex population as we have here. Primary care, specialty care, dental, behavioral health, of course, HIV care, healthcare for the homeless, substance use. Our breadth is extraordinarily broad and our patient population extraordinarily complex, and yet we can do this all under one roof. A medical home that is increasingly now even being brought into our patients' homes, so it's not just the roof of our clinic system itself, with the express intent of ensuring optimal outcomes for all. This is an unusual opportunity, these combined all together. The recent challenges between community care and central health have had a minimal effect on patients, thanks to the extraordinary effort of our staff. The effect on teams, especially managers, directors, and other leadership, has been hard. We've asked them to be patient. We've asked them to lean into their work with their enterprise partners. But to be frank, I'm worried it's taking a toll. That said, the opportunity that lies in front of us is one that we need to lean into and one that brings substantial motivation and inspiration to our workforces. I would say the same is probably true on the central health side. Amidst the current challenges, at the convergence of the health center movement, the growth of a new hospital district, the transformation of healthcare, U.S. healthcare financing, this is a moment we must capitalize on to build on the extraordinary potential that lies in the health centers as the medical home foundation for an expansive health system that will allow us to respond without delay to the local needs of our communities most in need. So you have our commitment that we will be building this future together. And again, we deeply appreciate the support you've provided thus far. Now on to the operational report. We'll bring your attention to the next slide, please. This has been, as every sequential year has been, a very, very busy year for community care. In this last quarter, we saw over 122,000 face-to-face visits, representing nearly 73,000 patients. This is a 7.2% increase over last year. The year ending at the end of September resulted in nearly 500,000 face-to-face visits provided to over 141,000 patients, which is a record for community care. This represents nearly a 10% increase in encounters and an over 8% increase in the unique patients served. We have been very busy trying to build different avenues to access. This has included expanding our telehealth services. We saw a 13% increase over the prior year. We've also increased eligibility to ensure patients feel comfortable and can afford to come to get the care that we offer. This includes an over 33% increase in MAP patient basic patients in the fourth quarter, with an increase of 23% in enrollments compared to last year. So a lot of work focused on building access to make sure they have immediate access to care. Next slide, please. We have also been remaining at the forefront of the healthcare transformation, particularly as we start moving towards more value-based frameworks, something that Dr. Lee and I have talked about at length, that is a unique opportunity for Central Health and Community Care's partnership. We are a founding member of the Texas Association of Community Health Centers Clinically Integrated Network. That's what that CIN stands for. It is now called My Texas, My Health, and it represents over 50 Texas health centers, which are focused on, and the intent is to reduce the administrative burdens on transitioning to value-based care for federally qualified health centers. This is a very exciting opportunity, and earlier this fall, we executed our first contract with an MCO. We expect many to follow. With this will allow us many different ways to move out of the more traditional fee-for-service models into one that is more value-oriented. We've also done a great deal to increase our process and patient care. To improve our process and patient care, we've gone live finally with a bidirectional interface with INTRAC. This is the state registry for vaccinations, so it allows us not only to deliver, to contribute to that repository, that registry, but now also to receive all the information back. This has resulted in a very satisfying recognition of the remarkable work that our care teams do in ensuring that our patients are fully vaccinated, boosting our vaccine rates above state and national averages. So this has been very satisfying for us. We have also started to expand access to hard-to-get vaccines for the uninsured at our David Powell Clinic, serving people living with HIV. I'll then turn it over to Tara for the next page.
Next slide, please. So I'm just going to speak very briefly to some of the grants and recognitions that we received in the last quarter of the year. One that we are extremely proud of is the fact that HRSA, annually they give out badges demonstrating where we rank in quality, and this year Community Care received a silver quality badge. This recognition takes into account not just how we perform on our quality indicators, but also the size and complexity of the patients we serve. Community Care is very unique in the sense that because of our partnership with Central Health, we serve a larger portion of uninsured adults than many other FQHCs. And so this means a lot, again, to our care teams, our leadership, our frontline folks, because it reflects the both desire, intent, and processes and quality that we believe all of our patients deserve. The other area that I will just sort of point out is the St. David's Foundation. We administer the Vision Voucher Program on behalf of St. David's. They have renewed our funding for another year and a quarter, which will get us through the end of 2025. They have indicated, they've had a leadership change recently. They're changing their approach to distributing grants, and so they will be moving to a more competitive environment, but this will give us, in addition, certainty for the next year and change on being able to continue to provide lenses and vision screenings for our patients while we develop a compelling proposal to address vision issues within our populations. And then briefly, I will speak to financials. Joyce Sloan, our CFO, did the year-end report. I will just say, as is our practice, in addition to the PowerPoint, you guys have the memo that includes a number of our key metrics, financial encounters, and otherwise. Joy did speak to the fact that we have flipped in terms of our payers, and so you will see that while there is tremendous growth, an increase of more than 80% for our sliding scale patients. The fact that the Medicaid payments have dropped so significantly is one of the reasons why we came back and are very grateful we've gotten some additional financial support, and is something that we are continuing to grapple with. Although these are not in the slides, we took guidance. Less complexity is better. If you're looking at the memo after the financial pages, I would like to show sort of underneath that increase of patient access, you will see a steady quarter-over-quarter increase in terms of numbers of African American patients, number of Latino patients. as well as the access that we are affording to our Travis County low-income residents, inclusive of uninsured individuals in the MAP Basic program. And so I know that it is really important in listening to the discussions on this board to not just be very high in terms of, yes, we are increasing in numbers year over year, and we are very proud that it is a record, but also that we are meeting the needs of the communities that are most important to this board. So I will encourage you to take a look. We now make ourselves available if you all have any questions for us.
Why don't we go through both items and then we'll hold questions for that? Well, unless, I mean, if you have to switch out folks.
Yes.
So, all right, well, we'll take questions now. I will start on this side. Any questions over here? Any questions?
No questions, just a comment. I can't tell you enough how much, I cannot say enough or stress enough how many people have called me or talked to me and talk in terms of community care and the excellent care that they receive there. I want to tell you that that would not be possible today were it not for the visionary team that was put together by your previous CEO and his executive team and the board of directors that manages it. I know for a fact that people like me wouldn't be here were it not for an entity as committed to excellence as you all are. And I want to tell you that you're a shining star in our Central Health Enterprise system, and I just wanted to make sure you understood that, and that your employees, your staff, your board, and your executives understood that also. Thank you.
Thank you, Manager Valdez. That means a great deal to us.
Dr. Martin?
Thank you for the presentation. Thank you for your good work. Does the feeling from community care, is there a sense of comfort and a sense of stability with access about funding and financial stability from your partners?
Is there, if I can repeat the question, do we feel a sense of comfort with our
Yes.
funding levels at this point?
And stability moving forward.
I will tell you that we are in the midst of some financial challenges, as we have made clear due to the Medicaid disenrollment. We're also in the moment of a very exciting transition to moving away from from fee-for-service frameworks into more of a value-based structure. This is a process that takes time, and with our partners at Central Health, we've been working through what that process looks like bit by bit. I would say we're in the early stages still, but we feel optimistic that we'll be able to make sure that the financial structures are sound for us going forward.
Thank you. And one last question alluding to that, to sort of the value-based care, which we're all big fans of. Do you all feel comfortable with the access to technology will allow that framework to occur to submit that data and collect those funds?
We have no concerns about technological disruption.
Super, thank you.
Did you have anything?
I did. The one thing that I would like to highlight for folks actually has to do with the federal side. I actually was in DC last week doing some advocacy with the National Association of Community Health Workers and, not workers, health centers. And some of the areas of, in terms of grant funding for our base grant and 340B is one of the areas that we're going to be continuing to look at and work on because there are some pressures on the horizon around that, which is different in a part that the whole puzzle comes together to make our work sustainable.
No questions, just thank you for bearing with the stress y'all have been under.
Manager Motwani?
Thanks, y'all. I have full faith that I think the financial ups and downs that come from Medicaid disenrollment and then changing in revenue sources by payer are going to be normalized and managed, I think, together by collaboration across the enterprise. And so my question is really more around that nuanced thing, the vision voucher program that I didn't actually spot necessarily the impact in the budget, but it seems like there's risk of not guaranteed renewal. I guess it's more competitive What is the impact if I know the probability is probably not that high that we wouldn't be renewed, but what is the contingency, I guess, in that case? Or is there enough of a budgetary impact to even warrant, or is it so fractional that we would probably be able to use reserve funds or something like that?
These are services that are very important to our patients, and we wouldn't want to let drop. They're not inconsequential, and so we'd have to do a little bit of planning about how we would make that. We would be able to make those ends meet.
But so we're committed to kind of hedging or sorting it out, even if, say, renewal is not a given. We're committed to funding that. Is what we're hearing.
So I would say that part of the reason why they gave us the extended runway and the heads up is to make sure that we are able to put together something that is competitive. I can't speak for the St. David's Foundation itself. We know that that this is a priority area for them. As we deal with all of the other pressures, we will need to figure out how to find money to fund it, but it is critically important to our patients, but not in a position to say 15 months out exactly how we're going to do that.
Okay. What's the dollar amount, roughly?
$1.7 million, I believe.
Manager Jones?
Thanks very much for coming here and presenting tonight. This has been a very difficult few weeks, so we certainly understand and admire you all coming here. I just have sort of a question, a concept question. Of the the four top hospital districts in Texas, how many of them utilize the model where FQHCs are part of them?
I'm not sure they answer it if you know. That may be something that we need to ask at another briefing. So, but let's see if they know.
My understanding is there's no hospital district that has the level of partnership with an FQHC as intimate as ours.
Okay. All right, so they
There
do know.
are
Sorry about
some
that.
have very small FQHC footprints, but largely it's through just separate
Oh, so
entities.
there are some that have a small footprint, right?
Yeah, my understanding is Harris Health has a healthcare for the homeless program that's classified as a federally qualified health center, but it is the scope of practice and the number of patients they serve does not.
Okay, all right, thank you.
Manager May?
I don't know that you can answer this question or not, but I'm gonna throw it out there anyway. And I'm assuming this percentage is gonna be small, but I'm curious to learn, what is the percentage of grants and/or donations that your budget is made up? And then have you identified, or are there plans to identify some potential other grants to come in and help with the budget?
I will have Joy speak to the exact number, but I will say that grants make up a fairly small proportion of our overall budget. Most of our budget comes from patient services revenue, whether it comes from Central Health via the MAP Basic program, Medicaid, or Medicare. Grants are an important part of our strategy, but funders are looking for projects that have end dates. And so the way that we have strategically used them is to invest in standing up programs, investing and sort of setting us up for success, as we have with some of our improvements and investments in Epic as an EHR. It is not a long-term solution for funding for team members or long-running projects unless we can find. So it's essentially startup funding. We have dabbled in donations and philanthropy and have had varying degrees of success in recent years, but it is not a strong income stream for us at this time.
Okay, I thought so, thank you.
Okay, I would just say one thing, and then we'll move on to the budget. I just want to echo what others have said, that we really appreciate the work that you all do, and your service to the community, and appreciate you giving us a heads up on the things that you've been doing. And I also want to say that we look forward to, or I'll speak for myself, I really look forward to developing a very strong collaboration with you all, and at the board level as well as the executive team level and your staffs. I know y'all have done a lot of work together, and you've had the opportunity to talk with each other, and you're building strength and working together. And I look forward to doing that at the board level also, as we get to know your board better, and find opportunities that we can have conversations with your board so that we can build that same kind of collaboration and understanding and strength together as boards. So thank you for being here. So I think that we have your budget presentation now. So
Thank you all very much.
Mhm.
Chair Kitchen, I'm not sure you read that one, the next item.
Oh, okay. The next item is item number 10. Receive a presentation on the fiscal year 2025 budget for community care health centers.
Thank you, Chair. This will be, my part of it's very brief, just trying to introduce the item. We'll be presenting, Joy will be presenting the fiscal year 2025 budget of community care. We'll bring the item back next month for approval.
Okay.
Just as and I think I've heard a couple of comments that allude to what I'm going to say, but Joy will touch a little bit on some significant challenges ahead of us related to 2025 that, taken individually, they're significant. If you take a number of them as a whole, they could be substantial. So we look forward to working with community care to work through those challenges, and I'll turn it over to Joy for the presentation.
Thank you and good evening. If you want to go to the next slide. So what I'm presenting to you today is the fiscal year 25 budget as approved by the Community Care Board of Directors. We start planning this budget very early in the fiscal year, and it gets approved before, based on a lot of assumptions. Usually, there aren't a lot of changes within the FQHC world, but what we're seeing right now is a lot of, to Jeff's point, a lot of turbulent times. So the budget is approved as a break even, but we'll talk a little bit in a few minutes about some of the challenges that might cause us to not break even this fiscal year. And this budget is really based upon a significant investment from Central Health. So about $74 million of our budget this year is committed from Central Health to cover MAP Basic, Travis County uninsured that are struggling to get enrolled in programs, as well as some specialty care and alternative visits. And so we're very thankful for that investment that kind of shored up some of the lost funding that we had happen in fiscal year 24. It also includes the absorption of cost. So Central Health also agreed to take on 100% of the enterprise HR and joint tech personnel cost. So that saved us about $6 million in our budget that we didn't have to try to cover. And Central Health also worked with us to cover 50% of the Epic hosting and maintenance costs and 13% of the associated third-party contracts. And so that was an additional savings from our budget of about $2.1 million. That doesn't even count the in-kind that Central Health provides in the way of facilities and equipment. So without this support, we would not have a break-even budget in fiscal year 25. And to the question about grants, grant and other revenue is about 6% of our total revenue. The other part of that is investments, which is very small. We don't have a significant cash balance, so we get maybe a couple $100,000 a year in interest earnings. So most of that, $15 million, is grant revenue derived. Next slide, please. When we consider services encounters, we are projecting a growth over fiscal year 24 of 16%. This is being contemplated by adding new initiatives, as well as just growth in patient access overall. We have in our budget 3 new care teams, expanded telehealth services with dedicated team members. We've got the Del Valley site coming on in hopefully February. We've got the second MAT team that will be at Capitol Plaza. And then we are expanding Bastrop to include pediatric care. And then there's also chronic care management for our Medicaid populations that's now available to community health centers. And it's reimbursable at the Medicaid PPS rate. So we're currently figuring out how to build that out and expand our case management care to chronically ill, or not chronically ill, people who have multiple health issues in the pediatric and OB world. So record encounters for fiscal year 25 are in the budget at almost 600,000. One of the challenges that we're facing, however, is provider turnover. So it is possible that we may not hit that encounter volume. Next slide, please. And then the other big part of our revenue generation is payer mix. And as you heard when we did the fiscal year 24 year end, a shift in payer mix can have a significant impact on revenue generation because it depends on what those payers are reimbursing us at. 53% of our budget is derived from services, and that is made up of Medicaid, Medicare, and MAP Basic, paid through the Central Health Services Agreement. So that's where the majority of the patient services revenue comes from. When we see a shift in that payer mix, it could be a positive, it could be negative, depending on whether we're shifting to a higher payer or a lower payer. It's also why value-based care really excites me. So about 133 million of projected revenue from patient services in fiscal year 25 is in the budget. Next slide, please. So we do have some significant challenges in fiscal year 25, as Jeff mentioned earlier. The 340B program continues to be a pressure point between the climbing drug costs, but also there are now changes coming in the Patient Access Program, or the PAP program, which allows patients to get medications at free or reduced prices. And those changes we know will significantly impact revenue in fiscal year 25. Provider turnover is higher than anticipated, and so we are struggling to hit encounter targets and struggling with what we need to do to really entice providers to come work for us and to stay. And Medicaid enrollment continues to be a challenge. So we budgeted 28% Medicaid. We're running about 25-26% right now. Given some of the indications with the new administration coming in January and the concern around being on governmental programs, we may struggle to have patients actually sign up for Medicaid and actually stay uninsured. So that pressure would mean that we would see less patient services revenue even if we're seeing more patients. So those challenges are real. We're still working out what all they're going to mean from a financial perspective. And it's going to be interesting to see how we end the year at a break even. And at this point, I can take questions.
Okay, we'll start on this side. If you have any questions, Dr. Zamora.
No questions.
Manager Valadez.
I just want to make sure that if you can see that there's going to be a fiscal challenge that we may need to help you with at Central Health, then please bring that to our attention as soon as sooner than later, so that we can make sure that that's incorporated into our budget as we begin the budget process, which we're basically doing now. So.
Yes, and we have begun discussing those at the executive level as we've been able to work out what we anticipate some of the impact to be.
And I echo again what our chair said with respect to our boards working together and helping us both to meet the needs of our patients. Thank you.
Dr. Martin?
I don't. Thank you for your work. A rocky road ahead this year. Thank you.
Dr. Brinson?
So what have you thought, what are the ideas people have to improve or increase physicians staying or hiring new physicians?
We actually have the executive teams meeting with HR tomorrow to start discussing what they can do and what the options are.
Definitely see that there's some potential turbulence ahead, but I wanted to note just how much I appreciate the forecasting. And just a heads up, early on, and we don't know what the answers are. We don't know where everything's going to land. But even just a nuance that, let's just say that we were to have more folks who were Medicaid eligible, they wouldn't possibly even get Medicaid, or even if we could wave a magic wand and recertify them, maybe they wouldn't because of these conditions, and that helps, I think, all of us calibrate our expectations around what the payer mix might look like and what the revenue mix might look like, as well as, of course, the suboptimal balances that results in. So just thanks for the forecasting, and I'm sure that we'll be hearing from each other as we go. Thanks.
Manager Jones? Manager May?
I just want to say, that we stand behind you, and certainly hope that and encourage the continued collaboration with our CEO and their executive team. I think that's crucial for all of us to be able to really come out ahead, or at least at a level that we're all satisfied at the end of this fiscal year, understanding that we've got challenges ahead. Thank you.
For sure. And I'll just, go ahead, Dr. Lee, then I'll close this out.
Okay. Just wanted to echo our manager's comments and to also lift up Dr. Yagoda's framing of the opportunity before us. The strength of the FQHC movement and our particular FQHC partner, the potential of our maturing hospital district and what is possible in our construction together, the overall move nationally toward value and locally toward defragmenting this fragmented health system, which is where so much breaks and so many people get hurt and so much waste is created. In those fragments, patients' journeys traverse the health center, the central health, direct practice of medicine space, and the central health contracted space, and go into areas where we don't yet have coverage at all. Our work is to connect that entire care continuum, follow the patients, and ensure that we can deliver that whole person care without delay together. There are significant financial headwinds this year ahead of community care, and I appreciate the transparency and the forecasting. We are working together diligently, and I appreciate Dr. Yagoda's leadership and the executive team at CUC. We have been meeting frequently, often, openly, and in a problem-solving, collaborative manner toward the mission. It gives me great hope. And I just wanted to acknowledge my colleagues' leadership and express optimism for our future.
Thank you. I would just close this out by saying, I forget who mentioned it, but as we're going into another future budget year in the planning process, I know you all are engaged with our executive team on a planning process. I think that we can talk about what's the best way to do this, but I think we'll look forward to engaging your board also. Our board started a new process last year, in terms of having more board engagement in the visioning budget process. And I think that there's a role for working with your board. And we'll think about what that might be and what they might be interested in. But it'll be good to have some conversations, I think, with your board in terms of our vision and planning together and budgeting and that sort of thing. So more to come on that. All right, thank you all. Okay, managers, we're now moving to item number 11.
We skipped over item 1, which was approval of the minutes for the Budget and Finance Committee, if you want to do that
I'm sorry.
really quickly.
Okay. All right, let me go back to item number 1, I believe it is, for, to approve the minutes of the November 13th, 2024 Budget and Finance Committee meeting. Can I have a motion from Manager Motwani, seconded by Manager Valadez? All in favor?
Aye.
Okay. Now we'll go on to item number 11, which is to confirm the next Budget and Finance Committee meeting date, time, and location. I believe the next one is tentatively scheduled for Wednesday, January 22nd at 4 p.m. At this time, I'm ready to accept a motion for adjournment from Manager Valadez, second from Manager Jones. All in favor? Aye.
Aye.
Okay. All right, we're going to move back now to the Board of Managers meeting. And we will start, I believe, at the beginning, which is, give me a minute, folks. Okay. Let's go first to our consent agenda. I would like to have a motion from someone to approve our consent agenda. That's from Manager Valadez. Okay, second.
I'll second.
Manager Motwani, all in favor?
Aye.
Okay. Now we'll move on to the item number, well, before we get into all of these, let's see. Well, no, we just have one. Let's go on to C6 is being put on the regular agenda. Okay. That's to approve the proposed calendar year 2025 meeting dates. Need a motion on those? Manager Valadez? Second by Manager
Second.
May? That was second, May?
Second, yes.
Yeah, all in favor?
Aye.
Okay. We'll move on to item number 2, which is to receive an update from Legislative and Government Affairs staff and advisors on the upcoming legislative session, and take appropriate action on Central Health's key legislative principles. So I believe that's Perla and Rob will be presenting.
Good evening, managers. Thank you for having us. I'm Perla Cavazos, Deputy Administrator. We wanted to provide a legislative update, seeing as how the legislature is set to begin January 14th. I also wanted to introduce our new Director of Government Affairs and Public Policy, Rob Borja, who comes to us from the Texas Senate and 25 years at the legislature. So we're really lucky to have him. As well, I want to introduce Marcia Jones, who many of you have met already, and she is our legislative consultant and advisor, a longtime advisor to Central Health, and we really do value her wisdom at the legislature. So we want to begin, I'm going to hand it over to Marcia to give an update first, and then in your board packet, there are some legislative guiding principles which have been provided, which I'm going to request action to approve those guiding principles. But I'm going to hand it over to Marcia.
Thank you so much, and it's a pleasure to be here tonight, and also a pleasure to see so many friends on the board, and for those that have not had the pleasure of working with until now, look forward to that. As Perla said, we want to provide some context to what we believe may be happening at the legislature as you look at your guiding principles. So next slide, please. You have to begin with where we are with post-election outcomes. And I would say that I just would say if I were to have a theme or a takeaway of what this group will be doing is learning a lot of new tricks. As being old dogs around the Capitol with lots of experience, because things are really, really changing, and even how business is conducted will be changing, and that is so significant because it does determine very often the difference between winning and losing. So who will be at the Capitol when the legislature convenes January 14th, which is a month and 2 days from now, not that I'm counting. There, first and foremost, more than any time in history, the tension between the two chambers is at a pitch that we haven't seen before. And there is a level of divisiveness between Republicans that are in the majority that will be playing out with lots of drama over the next month, and then the consequences of that will also play out during the legislative session. So anytime that you are invited to the Capitol, you should bring some popcorn because there's going to be some good drama. So the bottom line is really the last bullet there, and that is 88 House Republicans and 20 Senate Republicans that will come to Austin. And the 20 Senate Republicans I want to highlight with that last phrase, strategic procedural changes. So in the Senate, there's always been a voting margin that is a part of the Senate rules, and that seems pretty arcane. It used to be 2/3, which meant you had to get 21 members, and usually that was intended to create bipartisanship because you needed both our Republicans and Democrats to come together to get 21 of 31 votes in the Senate. What will be formalized is a 2/3 requirement of Republican members for legislation to come to the floor in the Senate. And so that is a significant change. Also gives the Senate even more control over what will pass, what will be discussed, and what even has a shot. So next slide, please. On the House side, and so before I cover this slide, I should say as a lead-in, with the last point, it means in a lot of ways that the Senate holds all the cards and that the presiding officer of the Senate will have even more flex this legislative session, and that is certainly playing out because of the divisiveness and also because of the majority that he has acquired in the Senate. So on the House side, there is a lot of disarray. There is a disagreement among the 88 Republicans about who should lead them. The House rules say that the Speaker is supposed to come from the Republican caucus, but the Republican caucus was not able to choose a Speaker candidate that had 2/3 of those votes. So again, that theme of 2/3. But nonetheless, the candidate that came out of the Republican caucus this last weekend is very, very close to having 2/3. There is a small group of, say, 28 Republicans and quite a few Democrats that are in coalition to countervail the House Republican caucus candidate. And I would say for the first time that I have ever seen, to the bullet of whether it is Republican Cook, who came out of the caucus vote as having the most Republican votes, or Dustin Burrows, who is the current coalition candidate, for the first time you are seeing presidential level influence being tweeted, having influence over what Texans think about their Republican, local Republicans. So to say that Donald Trump Jr. tweeting about the House Republican Speaker candidate being significant, it's also setting a precedent. So that is the level of profile that Texas has. and also the importance of Texas, and may influence who ultimately leads the House. And of course, you can probably do the flow chart of who might be aligned with whom. So, next slide. So what's our general outlook? General outlook is, as I mentioned, the Senate will be in control. Dan Patrick is who is the Lieutenant Governor, the presiding officer of the Senate, is in the process of determining his priorities. Last session, there were 31. He's already put out Senate Bill 3, which was to eliminate the availability of THC in Texas, which is already controversial even among his members, and even other elected officials that are members of his party. But you will see however many of those priorities that there are, they will be released probably day 2 or day 1 of session, maybe even before. Those will be passed very quickly and will be sent over to the House. The House, of course, as I mentioned, is not organized. They don't know who their leader is going to be. There are some statutory restrictions on how quickly they can move, but nonetheless, there will be lots of pressure to make decisions on the Lieutenant Governor's priorities, which I would say are usually a tiny bit controversial. And in the healthcare space, for a safety net provider like Central Health and the entities under the enterprise can be problematic. So we're going to buckle our seatbelts. So the bottom line also of leadership is that on the House side, because of the change in leadership, we don't know who will lead all of the health-related committees. And you can slot people according to what team they're on, but until you know what team wins, I can't tell you who's going to be in that middle seat. So what we have been doing is ensuring that we're talking to all of our friends and all of the possible candidates that could lead on healthcare policy. Next slide. So what are some expected healthcare themes? And I would first of all say, no surprise, state level initiatives based on Make America Healthy Again. The presidential election was November 5th. November 13th, so 8 days later, the Senate Health and Human Services Committee had a hearing that was related to examining the links between nutrition and chronic disease. And so if you look at quotes by RFK, there is a lot of interest in promoting sunshine, exercise, and healthy living to combat chronic disease, with lots of skepticism around medical interventions, vaccines, and pharmaceuticals. So, of course, that creates a challenging environment for innovative conversations about both healthcare delivery as well as innovations in healthcare products. So we're going to see a lot of that at the legislature, I think more so on the Senate side than the House, but that's something to be aware of. And lots of food as medicine, and maybe even some conversations about what is or is not a part of SNAP benefits, which of course is important to the population that we serve. No surprise, because you have been aware of immigration, citizenship status, and the healthcare intersection. That will continue to be front and center at a minimum. The expectation is that the governor's executive order on asking citizenship status will go into statute. Certainly, there is a broad coalition to ensure that federal laws prevail over state law in terms of ensuring that there is no limitation of access to care for patients that need that health care. Healthcare costs, of course, top of mind. You heard that in probably every budget that you have considered over the last, certainly tonight you heard it. Hospital issues like site-neutral payments and facility fees, which also play into budget and revenue. Those will be some of the headwinds that hospitals face, and then parental and patient rights. So parental rights has been very, very significant in the education space, so education choice. That is extending also to healthcare choice. And, what's important there is, what vaccine policy means, what mental health services can be provided, to whom, under what circumstances, in what environments. Are you able to do that in a school-based clinic, et cetera? So those are conversations that Central Health will be able to be a leader, and will also have some very important practical experience to bring to the table that will be important. On the upside, I would say that there was a Senate hearing on homelessness and how interventions that are like Haven for Hope, and Central Health was a part of submitting testimony to highlight several of the initiatives that you have underway, like Bridges and the healthcare partnerships. So that is an area where I know Commissioner Valadez, you've been very passionate, and that we will be able to be significant in terms of input. And also I think generally behavioral health and mental health policy will be leaders as well with our experience. So next slide. Potential threats, these will be themes that you have heard before. First and foremost is that Central Health happens to be in Austin, Texas, and Austin, Texas is not always viewed favorably by the legislature. In fact, there is a reoccurring bill that would make Austin like an island. We're getting voted off the island kind of thing. Which is just, kind of mean-spirited and also very politically motivated. But nonetheless, you also have some complicated relationships that have been highlighted with the legislature coming to town. That creates some potential threat for your friends and partners perhaps being up to mischief. So I'll leave that there. Political subdivisions and your ability to advocate at the Capitol and with whom. I also think tax revenue limitations and the elimination of both your authority as well as taxes will be again, front and center. I looked at a couple of pieces of legislation that were filed just recently, and one of them amended statute that we created almost at the beginning of Central Health to give you authority, and that is being, that's part of statute to change. For instance, it would require for you to increase your tax rate more than 60% of voters to approve, not just a majority, but 60%. So trying to set a level where it's impossible to try and cover what the community agrees are priorities. DEI policy is also front and center again, especially for public entities and political subdivisions like those that are represented by Central Health. Next slide. Time for questions and comments.
Okay.
I do feel from some of the faces a little bit like Grinch.
Well, just more power to you. That's all I have to say. So to all of you. Let's start on this side of the room this time. Manager May, do you have any questions or comments or anything?
One question or one comment. My biggest concern is this potential 60% vote from our property owners, if that should pass. That really does put us in peril since we've got these potential expansion projects.
Talk a bit more about that so that some of us are not quite as familiar with that.
Okay. So my understanding is from what you just said, that there is a potential, should it pass, that there is a bill already been filed?
Yes.
That would then say, if it passes, that the voter, in order for us to increase our tax rate, the voters of this Travis County area would have to approve by 60% in other words, 60% of those voting would have to approve that change. Is that correct?
Yes, ma'am.
So,
Is it, yeah, is it putting a cap on, or if we raised it at all, or if we raised it by a certain percentage?
It is the vote count required to increase your rate.
Okay.
And then also relatedly, there's legislation that would take away your ability to do other things like certificates of obligation and revenue anticipation bonds. I know that you utilize at least one of those. And so the legislature's view is anything that doesn't have a vote requirement is something that you shouldn't be able to utilize. And then on top of that, the threshold in order to utilize what limited taxing power you would be left with, the threshold will be quite high.
just to expand on, if I may, Madam Chair.
Yes, go ahead.
How many districts potentially in Texas would be affected by that, should it come to pass?
So the way that that bill is written, there is a provision that is specific to Central Health, because we had some language that was specific to us being a district that was created well after others, like Parkland had been around 50 years or more by the time Central Health was created. And so having looked at it but slept between then and your question, I believe that it would be for all political subdivisions, but there's something, a specific provision to ensure that Central Health, and it's not only Central Health, but it would be political subdivisions, and especially hospital districts.
Okay, thank you.
Okay. Manager Jones?
I'm not sure if I quite understood your response. I heard it, but I guess my question is, is this 60% relegated to all of the hospital district, all of the communities, I'm sorry, in which hospital district votes may occur?
Yes, sir. So Central Health would not be treated differently. All districts would have an increased threshold.
Okay, so that is something other districts should be mindful of as well.
Oh, absolutely, as well as cities, counties, water districts, any political subdivision that's created by the state.
All right, thank you.
And in fact, of course, school districts.
Last session, we saw, the approval of Medicaid reimbursement for CHWs and doulas for pregnant women and children on Medicaid, and so I see opportunity this session, given the angle of health priority around non-medical drivers of health. See opportunity there.
I would agree with you, and I would also say that I would be remiss without mentioning that the Texas Medical Association, one of their top priorities is to increase for all physicians Medicaid reimbursement. Last session, there was a target increase for certain populations, which essentially was pediatrics, but not all pediatrics. But so I agree with you that there are opportunities in addition to reimbursement, but coverage of other kinds of healthcare expenditures that you have to try and manage in your budget by creating revenue to pay for something that's not paid for. So that's a very fair point.
Dr. Martin?
I'd like to know whether or not you all will be able to send us in advance, if we could develop our own personal SWAT team. Heads up, this is a hearing. It's at this such and such a time in this room. We could always send in an email or fill out a card or whatever in order to make sure that our voice is heard in the various hearings. Is that anything that you would anticipate or could anticipate seeing us play, in a part in that role? Because I know I do that for other organizations. I sure as hell can do it for Central Health.
Yes, and I really appreciated the chair's comment about board engagement across a lot of functions of the enterprise, and would welcome participation from the board at the legislative level as well.
Okay, so you will be able to send us out, look, those little, Bedla, you'll be able to send us a.
Rob and I can do that,
text.
kind of
Yeah.
think strategically about where
Correct.
are the opportunities for advocacy.
Thank you.
No questions, just comment. Marcia, thank you for everything you've done for us in these last few years as I've known you. And I also agree with Manager Valdez that if you need me to go testify on something, just call me. You got my cell number, and I'll be happy to go up to the Capitol.
Thank you.
Couple of thoughts. Yeah, use us if we can be helpful. We understand that sometimes Austinites are not helpful, so we'll leave it to you to tell us when we can be. So there's that. And then I have a question or two on the reimbursement. Is there going to be an effort this time, or is there any more effort around the personal care workers? That's been a continuous thing over the years about raising the rates.
Personal attendant wages.
Yeah, that's what I meant, personal attendants.
Yes, and Dr. Valadez, Manager Valadez, you may have more insight than I do about what this specific legislative proposal is, but it is a perennial issue for good reason. And so while there was an increase in payment last time, I do expect that there will be another effort to increase those wages, and so noted that it is a priority.
Yeah. Okay. And then I think the points that were raised around SDOH would be interesting for us to keep an eye on. Immigration. And the intersection with healthcare would be something for us to keep an eye on. And then I'm curious also about, in some places, there's discussion about, or there are some other states where Medicaid covers housing. Sometimes as part of managed care as in lieu of service. So it provides some flexibility for the managed care organizations to do that. Do you know, or if there's any conversation here in Texas about some opportunities around Medicaid related coverage?
So what I can speak to, and I appreciate the conversation about medical, other drivers of healthcare, and certainly housing is one of those, food insecurity, transportation, all of those being issues that that any population, it's important to any population and their healthcare status. So there are some Medicaid managed care plans that I'm aware of that offer value-added services in the housing space.
Okay.
In terms of in lieu of services, mostly that's been around mental health. But so I haven't heard it around housing, but I'm making a note of going back to the Capitol and asking some questions about what that might look like.
Yeah, I'm just curious if, because it's one of the areas that's been flagged, is housing and homelessness. I'm just wondering if there might be some opportunities to access some additional funding for that in some way, whether it's a reimbursement kind of thing, or if it's a coverage kind of thing, or something else. So.
Well, Madam Chair, excellent point. And I know the first office I'm going to is the Senate Chair of the State Affairs Committee, who held the hearing on homelessness, because that was not part of the discussion. And it is a very real problem with a real solution that is available to us. So that's something that we can do quickly.
Okay. And then my last question is, I guess it's for Perla and you guys. The action that you'd like us to take is on this agenda.
Yes.
There's a couple of things I didn't see on it, except that they may be inherent in what you're saying. Right. So, and that was the the SDOH issues, keeping an eye on that. Maybe you're considering that to be under one of these. And then the other one is immigration, because I didn't see that on the list either. You can, if you consider it to be inherent in something, that's fine. If not, I'd like to consider adding.
I mean, I consider those inherent under local control.
Okay.
And really, that local, these are guiding principles. They're not,
Yeah, they're
they're
not
meant
specific,
to be inclusive. And I think local control covers a lot of the threats that Marcia stated. I think,
Okay.
It's wanting to control the ability of hospital districts and local entities to decide how best to use its resources to serve the unique needs of its individual community
Okay.
members.
So those would be two areas that you all would be tracking.
We're definitely tracking those.
Okay. Okay.
Yes.
All right. Well, then I think we might be ready for a motion on this item. Is there anything else you wanted to say about it, Pearlie?
I also just want to acknowledge Katie Coburn in the room and Paul Emerson, who's in his office listening as part of our legislative, core legislative work group that meets now bi-weekly. And, there's other attorneys in the room that we also lean on for assistance during the legislative session. But it's, it takes a village to track the thousands of bills
Yes.
going through the legislature.
Y'all will be very busy, or you're already very busy. So, okay. Well, I'm ready for a motion on that item number 2.
I move that the board approve Central Health's key legislative principles.
Second. Manager May? All in favor?
Aye.
Aye. Okay, thank you very much.
Thank you.
Okay, managers, we will now move on to item number 4, yes. Discuss and take appropriate action to execute a professional services agreement for subrogation services. So managers,
Kitchen,
item
I'm
number.
sorry, did you want me to provide any updates from
Oh,
CEO
for you?
or?
I didn't see it. Did you want to go next?
I'm happy to go whatever order you.
It's fine with me if you want to go next. I didn't.
Okay.
I'm sorry, I missed it.
No, not at all. Not at all. So I'll be brief because I know time is late, but they were.
Sorry, Dr. Lee. We had crossed that one off because of all of that back and forth in the emails today.
Okay.
If you could read that one out, even though it's crossed off on your script.
Oh, okay.
My apologies.
Here it is. It's item number 3. Receive and discuss a report from the President and CEO on Central Health's current activities, operations, procurement, workforce, including new positions and related goals and objectives. And managers, we have been talking about making this a standing item. So we'll be doing that going forward so that Dr. Lee has the opportunity to update us on things that are top of mind for him. So I think it's something that the board used to do.
Yes,
And so
we always had a singular
yeah, and they
report.
fell off for whatever reason. But anyway, so we're adding it, and so this will be a regular agenda item. So.
Thank you, Chair Kitchen and managers. And just say up front that I welcome feedback and input for what you would like to hear in this segment. But today, I just had 5 brief points that I thought I would share. I just want to first acknowledge Manager Jones. I had an opportunity to be with Manager Jones and others and our community care colleagues at the NAACP Annual Freedom Fund Banquet this past weekend. And President Nelson Linder was very kind to offer us an opportunity to share a few words of welcome, which was a privilege to do. We led off by lifting up Dr. Martin Luther King Jr.'s words that of all the forms of injustice, injustice in healthcare is among the most shocking and inhumane because it often results in physical death. And we went from there to talk about who we are, what we do, and lifted up our partners in the room, including the Black Men's Health Clinic, the African American Youth Harvest Foundation, including the Trauma Resource Center. We are adding $800,000 of support for the Trauma Resource Center this year, $500,000 this year, and again next year for the Black Men's Health Clinic. and then working with Hungry Hill Foundation around moving folks from homelessness to stability. So there was a lot of appreciation in the room as our partners were present as well. So just wanted to lift that up, and thank you, Shannon, for helping to facilitate and make that possible. Second key update, I actually wanted to introduce one of our new senior leaders, Kim Heinen. Kim, do you mind coming up to the... we'll keep it real brief, but I want to introduce Kim. Kim is our new Chief Transformation Officer. Kim brings a whole professional lifetime of experience in transformation, coming to us most recently from Kaiser Permanente, where for about 10 years he was integral to that health system's approach to doing what we hope to do. And while there's a lot here, I'll mention just briefly that there's a way in which organizations manage vertically, which is necessary, but there's a way in which patients travel horizontally and get lost across the verticals. And that's easier said than addressed, but what we aim to do broadly is to get really good at following that horizontal weave to make sure we understand what is the value that we want to create with and for this individual or this group of patients, or what other value are we trying to create as a piece of information travels across these verticals, or a piece of equipment, or medication, etc. It is the horizontal weave that needs to be stronger than the vertical weave, as Kim has begun to teach us. And how do we do that? Easier said than done. And so that's amongst the kinds of capabilities that we believe are absolutely essential to the kind of health system that we want to build, that is patient-focused and can be patient-focused, because we've built the structures and the capabilities to actually work horizontally and follow those journeys and improve them continuously. So I want to just give Kim a moment briefly. I know more to come, but just to say hello and to say a couple words.
Good evening, Chair Kitchen, Board of Managers. It's a pleasure to be here. I wanted to briefly touch on three things: my background, what does a CTO do, and then my top priorities for 2025. So I spent the past 20 years in management consulting as an executive consultant in the operations practice of IBM's business transformation services, and 15 years out of 20 in healthcare delivery improvement. And as Pat mentioned, 10 of those with the Permanente Medical Group as a Kaiser Permanente in Northern California. What does a CTO do? Promote innovation and performance improvement, help navigate significant organizational change, implement strategic imperatives, and closely collaborate with the senior leadership team. So this is basically, there's other things that I'm going to do, but those are kind of the basics. And top priorities for 2025. The number one is people development or leadership. Just a little closer so we can. Leadership development. So I'm partnering with Jeannie to develop a leadership development program, and my part of that is operational excellence and problem solving. So the idea is to turn the entire organization from top to bottom into problem solvers, so that we don't just have a small group of people improving. Everybody is going to improve their own work. The second thing is strategy execution. So I'm going to work closely with Monica to implement the strategic imperatives. And the third one is collaboration with CUC, Dr. Yagoda, and Nancy, the COO. And the last one is facilities design. So look at new innovative approaches on how to design facilities. So I'm going to work very closely with Stephanie McDonald. So any questions? Thank you.
Yeah, welcome.
Thank you.
So, did I hear you say you were in California? Is that right?
Yes. So actually, I live in or I used to live in Dallas.
Oh, okay, so you're
Yeah,
not new to Texas then?
No. So,
Okay.
and I traveled in
Okay.
my consulting role, so I was on the road, pretty much 100% of the time. And my client base was in California.
Okay.
And people always ask me, why don't you move here? I says, I can't afford it. So it's cheaper to fly.
Okay.
And I have a personal reason, why I came here. So my daughter lives in the community, and I have a granddaughter who turns 12 months on the 15th. So that's why I wanted to be here. So it's
Well,
exciting
welcome.
for me. Yeah, exciting for me to improve the services here for the community.
Welcome.
Thank you.
Yeah, thank you, Kim. Welcome. All right, up number 3 is to just to briefly share, Lucas Bustelo provided a readout of the delegation trip to Denver to learn about homeless services. Just want to very briefly share that work continues to build and flow nicely. So I think this may be a theme that I will continue to bring, bite-sized updates back to this group, because I believe it's something that we are all committed to and know how important it is. So just the brief updates here. There was a nice debrief that was led by the Homeless Strategy Office with the same group of 30 plus additional staff members to continue and build on that work to harvest the learnings and identify key priorities. In this past month, we have actually gotten access or signed the contract to get access to the HMIS system, which has been years in the making, and will allow our teams to work much more closely with other stakeholders at this space, and more directly serve our patients and coordinate care with others. So that's great news. And another piece of great news: the day we got back from Denver, the ECHO team reached out to us and began to work with us around what we had been talking about conceptually for months, which is to allow Dr. Audrey Kwong or Dr. Tim Mercer to write a prescription for the home that somebody might need. In particular, the very medically and behaviorally vulnerable patients who come out of medical respite. We know that those folks have 5 to 8 times perhaps the baseline rate of physical and behavioral and substance comorbidities. And so we have actually made significant progress in family elder care, and I believe begin to work with our RBJ. And so there's a team that's actively working, and just every month I'm getting a pulse update. And so the work is beginning to move. It's very exciting to have gone from a place where you may have seen that winding road concept design slide to a place where the work is actually beginning to move. So delighted to share that update. The fourth quick update, I'm going to invite Dr. Alan Shalshab just to very briefly share some lovely recognition from the Travis County Medical Society awards to some of our physicians. And I believe we have a brief slide, if it's easy to pull up. Perfect, thank you.
As you're doing that, just a heads up for everyone, we were going to get a more detailed briefing today around the homeless work that's happening. Because of time, we pushed that to January. Perfect. So just know that we'll have a more detailed briefing in January. So, thank you.
All right. Hi again. Last week, Travis County Medical Society had its annual business and awards dinner. And, standing in this photograph are really executives and clinical leadership between Central Health and CUC. Personally want to thank Dr. Zamora for his support. He's always a huge support to all of the, growing clinicians and maybe ones who have grown in our environment and advocacy for the under-resourced. This year, Dr. Hamali Patel, our Director of Transitions of Care, won the Humanitarian Award from TCMS, and Dr. John Weems, who's an addictionologist within CUC, won the Young Physician Award from the society. That award had previously been won by Nick, and then Audrey and I have also previously received a humanitarian award. So it's a pretty, I would say, effective team. And the society is very supportive of the work that we're doing. I also wanted to announce that Dr. Ashley Trust, our Director of Psychiatry, was announced as one of Austin's top docs, and so was Dr. Michelle Owens, our Director of Specialty, who's a palliative care doc, and she was awarded that within palliative care. So, thanks.
Thank you, Alan. And last but not
Congratulations.
least, a very brief update on diabetes community education. Sort of run up to this, Manager Valdez had introduced me to Mr. Frank Fuentes a little ways back. Frank and I have been getting to know each other. And as we've been talking about the health needs of his constituency, diabetes has very much come to the fore. I was introduced by Frank to the Mexican Consul General, who echoed, what a scourge this is, and disproportionately affecting Mexican Americans and Mexicans in the U.S. And so they asked us, can you help us develop an education campaign to begin to reach out and provide those right messages? We can provide those channels that people know us and they want to hear from us, but can you help us provide the content? And so we are in the beginning of that work. I want to acknowledge Ivan Davila from our communications team, Alan Shalsha, and others. And Ivan, I believe, is going to come up and share just a little brief snippet. We just want to give the board a flavor of what we're working on. So, Ivan, if you're able to. Oh, we canceled? Okay. Okay. Well, they're doing a great job. And there was going to be a flyer that we would show you. And I think they have really nicely, carefully framed the language. So hopefully it feels accessible. The messages are clear, not too complicated, provide an easy way to access the information on a QR code or on a website. And we'll continue to take feedback, and it's exciting to be able to work with our partners to get the right word out through those high trust channels. And so thank you, Manager Valdez, for making an introduction, and as always, open to feedback to how we can improve that outreach. And that concludes my report for the month. Thank you.
Thank you. Appreciate the update. Okay. Oh, did you have something?
Yeah, I mean, in addition to the other humanitarian award winners, I mean, I know Dr. Zamora, haven't you won a Humanitarian of the Year award?
We gave him one.
Oh, Physician of the Year. Oh, we
Don't
gave
forget
him.
the award we gave him.
Oh, yeah. And I guess Dr. Brinson probably has them falling out of her purse. Humanitarian awards. I don't know. And did Dr. Martin, did you win a humanitarian related? Yes. Yeah, and Dr. Martin, what was the name of it? From the medical school. Yeah. Well, I mean, I just think it's really neat to be in this caliber of company.
Thank you. Thank you. Okay, we're going to move on to our next item, which is item number 4. Discuss and take appropriate action. 4A is to execute a professional services agreement for subrogation services. And managers, item number B, which relates to amending the Central Health bylaws, we'll have to take that up in January because there's requirement for 7 days notice. So, but the effect of what needs to happen for Dr. Lee to be able to take action is A. So we'll be able to take that up. If you want to go ahead, Jeff.
Yeah, thank you, Chair Kitchen. Yeah, I'll make this quick. It is a two-step process, so this is an item related around subrogation. It's a natural function as we build out a provider network that we begin looking at initiating this process. So as Manager Kitchen mentioned, this is a two-step process. Tonight, we're requesting action to approve delegation to execute a contract related to the services. And then again, we'll be back in January related to the amendment that we need to the Central Health bylaws. So just real quickly, next slide, subrogation really simply put is just a seeking recovery for medical expenses that we, Central Health, would provide that really are the responsibility of a third party. And that third party is typically as Central Health may treat some of our patients related to third-party, such as workers' compensation or even automobile or types of accidents where there are third parties. Next slide. The scope of subrogation services, just generally speaking, is just identification of potential third-party responsibility, investigating and negotiating, and potentially initiating legal action if necessary, recover funds, excuse me, and then just closing out any legal process or processes that were initiated. And then secondly, subrogation firms, and what we're proposing to do is they would be a percentage of the recovery. Next slide. And as Chair Kitchen mentioned, the bylaw amendment process, I won't bore y'all with this, but we are proposing explicit language. Article 9 of Section 13 requires a 7 working day process to explicitly list the amendment, and so therefore we'll be back in January to request approval. And then the next slide is the actual, excuse me, the actual proposed amendment in Section 9 in Q, just delegating authority to the Central Health President and CEO related to recovering patient treatment costs that are the responsibilities of third parties and settlements of such actions up to $100,000. Next slide. And so this, again, is just a reiteration of our proposed action for tonight. I will mention that the subrogation firm that we're contemplating is under contract with Sendero, and again, this is another example of trying to utilize some of our tools across our enterprise to leverage some of the services that both of us or all three of us could utilize at some point. So that concludes my presentation. Be happy to answer any questions.
Okay, any questions, anyone? Okay, Dr. Martin?
Just educational point, why is there a $100,000 limit on the subrogation?
We're just a provider, we're not a hospital system, so just kind of sizing what we think, where we need to start. $100,000 sounds like a good place to start from a delegated place. In the future, if we think it needs to be increased, we would just come back and request approval to increase that amount.
I'm just curious, hospital bills will routinely run to $250,000, $500,000.
Yeah, we would not be in the business of recovering hospital bills. Okay. That's Ascension's role. It's really just our direct practice at this point.
All right, thank you.
Is there a reason that Central Health would be interested in going after one of our patients for our targeted population of poverty? I'm just curious. I'm trying to understand.
This is not for patients.
Oh, it's not for patients?
No.
For insurance, okay, for insurance purposes?
It's like workers' comp, for example, or
Got
stuff
it.
like that.
Okay, I just wanted to make sure that nobody's going after somebody's lack of money.
It's third-party payers,
yeah,
right?
The example would be we're treating a patient of ours, and they're getting treated, for example, if they were in an automobile accident where they weren't at fault. So there's a third party that's involved. So we would, of course, treat our patient, but then we would try to recover the costs through that third party insurance.
I appreciate that. Thank you.
Okay, can I have a motion on this item? Number 4.
The board delegate authority to the president and CEO to negotiate and execute an agreement for subrogation services.
Second. Dr. Brinson, all in favor? Okay, passes. Thank you. Okay, we're now going on to item number 5, which is discuss board compliance policies and procedures related to compliance program, description policy, code of conduct, reporting and non-retaliation policy, duality and conflict of interest policy, and duality and conflict of interest procedures. So, thank you.
Good afternoon, Board of Managers. Thank you for this presentation time. My name is Mackenzie Frazier, and I am you all's compliance officer. I do not have a presentation to display today, but the five compliance documents are referenced in your packet. This is an annual update of the compliance policies that support the structure, culture, and transparency of the Central Health Compliance Program. Worth noting, as we continue to expand our practice of medicine, I will begin and have begun creating policies that will support the practice of medicine. Some that are out now are our fraud, waste, and abuse policy. In the pipeline, we have inducement, prohibition of inducements, and Stark and anti-kickback policies that further align our business with the practice of medicine. Are there any questions?
Any questions, anyone? This is an informational item, right?
Yes, it's information.
Okay. Seeing none, thank you very much. Oh, well, let me ask you this. Are these policies in the backup?
Yes, they are.
Okay, great. Sorry. Thank you very much.
You're welcome.
Manager,
Go ahead.
Chair, are we going to be discussing this in January's meeting, or?
No, not this item. It's the previous one about the bylaws that will come to us in January. This is just an informational item for us.
So this is what exists correctly?
Yes.
I mean, currently?
Right.
Okay, thank you.
Okay, thanks. All right, we will now go on to, I think that's our last item, right? Okay, so we are going on to item number 11, which is to
Did Monica want to do?
December 11th, the time is 8:09. We are going into closed session for item number 9. Receive and discuss a briefing regarding the Travis County Healthcare District, DBA Central Health versus Ascension.
And we're going in under 071. You have to say the exception.
Oh, okay. We're going in under Texas Government Code, section 551.0, did you say
71.
071, consultation with attorney.
Perfect. And you already said the date and time. We're good.
Yeah, I already said date.
Edwin's got to put us in closed, and then we'll be there.